I'd like to start by thanking the organisers for giving us the opportunity to present our data today. My name's Ian Morrison. I'm a consultant neurologist in NHS Tayside. I was lead for the project alongside my colleague Mr Patrick Sullivan. I'll be doing the introductory section to the talk, and then Patrick will be giving you the results towards the end of the presentation. A few declarations of interest, none of which I think are directly relevant to the talk today, other than to note that the study was funded by the Gordon Aikman Award. Now, our service in NHS Tayside is relatively unique in the country. Rather than being a consultant-led service where we see the patients back every 4 months or so, we are primarily a patient-centred, nurse-led service. And that basically means that the patients have open access to see me as a consultant neurologist, really on a monthly basis. But out with that, they are viewed regularly by the nurse specialists in a time and location that's convenient to them. Very often this is by telephone, on other occasions it can be in the patient's house. Alongside this, because NHS Tayside is a semi-rural area, we try to have community-focused engagement as well. So we have a number of community-based clinics that are one-stop clinics. Rather than patients having to travel to a large tertiary referral centre to see, for example, physiotherapy or occupational therapy, we arrange for them to be seen in their local area to save them travelling. Alongside this, we were an early pioneer of telemedicine, using the internet and telephone to contact our patients, again, to save them having to travel vast distances. And then we also try to encourage community engagement alongside several MND charities, particularly MND Scotland, which is very active in our area. And our service has been supported by audit and pathway development, and also assessing our practice against nationally agreed competencies, particularly at nursing level. Despite this service, we became aware there were a number of issues that had arisen that we could not address in our clinical service. First of all, we became aware that MND was not an illness that had one single bereavement at the end of the patient's life. We found that patients would often experience a series of bereavements throughout their illness. That started at diagnosis, but then also continued when patients were having a fresh loss of ability or function, so they were constantly grieving as they lost their abilities. And this wasn't just for the patients, this was something that we saw with their families as well. We became very aware that despite trying to put a focus on community support, community engagement, doing things in their local area, we still found that MND was quite an isolating illness, and that it also presented a number of barriers to engaging with friends and family. That wasn't just the loss of speech and language, but it was also physical disability that prevented them from going to interact with families at events. We were also aware that although we had very good neuropsychology support and also very good medical intervention, what we couldn't do was address the injustice of motor neuron disease. Patients would regularly tell us that they were very frustrated, why was it them that had this illness? And our focus very clearly at that time was on trying to make the patients better rather than perhaps addressing that injustice. And another thing that's very difficult, I think, for us to think about is that people often find it difficult to be honest about their illness. The media, the internet will often present people with MND as being heroes, these kind of heroic figures, the sort of face of national campaigns. And that's often not a patient's experience or their family's experience. And they found it very difficult to be honest with the challenges that they faced in their illness. And we were looking at how to deal with this when this paper was released by the Scottish Government. It was looking at the role of chaplaincy in chronic illness, and we then brought our chaplain into our MND service, and it was immediately successful, not only in addressing the areas that I've spoken about, but other areas as well. And that led on to our study, which Patrick will now talk about, so I'll pass you over to him.
Thank you, Ian, and it's great to be with you all and tell you more about this project we were very passionate about. It must be said at the outset that chaplains in general around the world offer various forms of great pastoral care, but the style and delivery understandably differs in some ways due to the culture that each finds himself in. So I'll briefly outline the Scottish context, then explain how the service developed with MND work in Tayside, what was actually done, and then how did we evaluate this. Ian referenced the national framework from Scottish Government regarding spiritual care, and this has been in the works for a while, and these aims outlined have indeed been adopted by NHS Tayside for a while and are a part of Scottish chaplaincy. But one of the issues it tries to cover is that religious care, at its best, should always be spiritual, but spiritual care is not necessarily religious. There's natural preconceptions when it comes to chaplains, and that would be that people would only use a chaplain if they were seeking some kind of religious need. You'll even see on our webpage for NHS Tayside that we try to show the various forms and reasons why someone might contact a chaplain. We often say that spiritual care is more than you think. Chaplains are here to offer person-centered care during times of illness, transition, and loss, regardless of someone's background. It might surprise some of you to see that our overall offerings, even in Tayside, amongst the full breadth of our chaplains, over 80% of the work is not faith-based in any way. 20% definitely is, and we're so glad that we could offer that. With MND work, it ended up being just around 7%. And the reason that that was religious, or that religious care offering was given, was because those were the needs that were expressed by the patients involved. The primary reason that Ian contacted us, though, to develop this service was outlined in this next quote. Within health and social care, it's widely accepted that questions of meaning, purpose, hope, or lack of it, identity, and relationships can become acute when well-being and stability are challenged or threatened by illness, injury, or loss in oneself or a loved one. At such times, people often need spiritual care. Ian referenced earlier the series of bereavements that happen to someone going through MND and their family's experience. Now, I was privileged to come alongside the service as we were asking the question that how do we support these constantly rolling and cumulative losses and bereavement experiences? I often work in images and stories, so the image of a train really came to mind for me. And you may have been in a situation where you've seen a train going by at a level crossing and just wondered, how long is this train? How much are they carrying? This became the understanding of all these numerous losses that someone would go through. And we were asking the question, well, what would it look like to put in a different form of pastoral care than was already being offered in MND services? I love this next image because it shows a track diverging. And even if the final location is the same, the journey will be different because of the landscape that each track goes through. So this is the way of our thinking as we try to develop embedding pastoral care within MND service offerings in Tayside. What we did was we started by just a few referrals a month, and this was a lot of just trial and just listening to what patients and families' needs were. As we continued on this journey, we started to understand more of what those needs looked like as they expressed and told us more, and this then, of course, increased. As such, we realized we were going to need a dedicated resource. It wasn't going to be enough just to have a few referrals here and there. So we applied to the Gordon Aikman Foundation and were successful in getting funding to conduct this project for dedicated chaplaincy support for 1 day a week. As such, this became a full team embeddedness approach. We decided to view it not just as a referral to a chaplain or into spiritual care, but that the chaplain was very much a part of the MDT for motor neuron disease. They were part of the team. There was the consultant, the specialist nurses, and the family and patient support as delivered by a chaplain. There were challenges, of course, to this, one of which I already mentioned was the vast increase in numbers of people needing the support, but then also how do we make that accessible? The language. If you ask someone, would you like to see a chaplain, you often get all the preconceptions about what that might mean, as we mentioned earlier. So what we began to do is say we have someone who offers support for patients and families. His name is Patrick, and he's a chaplain. Now, this is not hiding the fact that I was a chaplain. I've never done that, but it was trying to present it before patients and families in a way that was accessible and they could receive. This then became part of a full journey approach. I wouldn't just begin supporting someone at various complex stations or moments, but actually from diagnosis. And we found that those I was able to support from diagnosis, I was able to offer support on a continuous basis all through their journey, up to the point of death for many situations, and then bereavement supports for families afterwards. This was done in a number of ways. I would offer what I call person-centered versatility. If they needed or were more comfortable speaking on the phone, we would do this. If they were coming in for a hospital appointment or a clinical procedure, then I would meet them there. But by and large, most of the support was delivered in the home. and then occasionally an alternate setting for family members who might want a little bit of respite from that caring environment. This was delivered through pastoral listening in all these situations, assets and values-based approaches, as in whatever they presented to me. I never went in with an agenda. We would explore things from the past, those current and present losses that they're accumulating, and potentially their anxiety or concern about the future for themselves or their loved ones. As this developed, I became more aware of what MND did to an individual and a family. I learned so much from the nurses and from Ian, and we were able to offer a much more comprehensive support service as we worked better together. We would notice, as I'll explain in just a second, a transition of support from just patient to patient and family to sometimes more family. And this was then even made more apparent when there was continued bereavement support that was needed. The breakdown here shows you that it did end up being more family that needed support than the patients, not in any way ignoring the patients at all. It's just that as the support needs were identified, it became apparent that the family needed a bit more depending on where the illness was in its journey. Sometimes you'll see on the right that this was patient and family together, or just patient, or just the family, and then a huge section of bereavement support. When we wanted to evaluate this, we were aware that it was working. We were hearing that it was working. We knew this anecdotally, but we wanted to get official data to show this. So we looked at using the Scottish Spiritual Care PROM, the Patient Reported Outcome Measure. It's a wonderful tool being used all around Scotland to determine the efficacy of chaplaincy interventions. It did show us some results and that the support was valued. However, it didn't tell us why, and this came from a number of different reasons, one of which is it is a snapshot at any given period of time at how someone's doing. And because of that continued journey and each of those additional bereavements and losses over the course of someone's MND journey, it just became clear that this wasn't going to be the best tool, albeit a wonderful tool in other situations. So we moved to semi-structured interviews. There's a number of benefits from doing this. We used a alongside service called the NHS Tayside Listening Service. They very skilled listeners and practitioners who were able to conduct these interviews for us. They interviewed one current patient with their spouse, one wife of a current patient, although the patient themselves were unable because of their illness at the time, one son or daughter of a patient, one bereaved spouse, and one bereaved son or daughter. As they delivered this, it was very much a person-centered, compassionate environment. They were able to sit with people, usually on Microsoft Teams, and meet them where they were, asking some pre-prepared questions, but also allowing the space and flexibility to just listen and hear whatever the patients or families wanted to express themselves. Another reason to believe this worked so well is that it actually mirrored the support that was given. It indeed did give us some wonderful data to show why this worked. And some of this we already had in our thinking, is that we're able to provide tools in a different way from the chaplaincy spiritual care approach. It was able to help them see things in a different lens and talk about things that they might not have discussed in a clinical environment. Being the versatility of being able to do this wherever. And also that full diagnosis experience was also highlighted a number of times. We also spoke to the specialist nurses on what the benefit was for them. And again, they offer wonderful pastoral care, but they still have that clinical hat that they need to follow through with, and sometimes weren't able to offer as much, so an actual need to sit and listen with someone. And also explore issues of hope, purpose, meanings. Again, the patient's agenda, not my agenda or anyone else's agenda. So the full journey and how this looked, we were able to see that it was deeply valued by all. It was partly become a non-clinical way of being from that spiritual care, pastoral care approach. The ability to journey through each of the additional losses as they occurred in real time. That this was not an external service, but as part of the overall support from MND, and that it was better when it was done through the full journey. And it was mutually beneficial to staff as well, as I learned from them and I was able to support them as well. I want to thank everybody who was involved in this, and I look forward to talking more about this and answering your questions. Thank you very much.
Hello. Hello. Hi, Patrick. That was phenomenal. Such an important topic. One thing that jumped out at me was when you said spiritual care is more than you think. And you're right. And that there's a difference between spirituality and religion. I think sometimes those things get conflated and we don't see those differences. So thank you. Love to take some questions from the audience. Anyone down there? Oh, okay. Sorry. Hi, Joe.
Hello. Hello, Joe from MND Victoria. I was just curious how many people engaged in the program over that time period, and how did you structure it in terms of, you said 1 day a week was available to this program. So, and I'm thinking of this because we're looking at some emotional support for people that we support in Australia, and just kind of thinking about how did you manage to sort of work within, did you say, okay, I'm available on a Friday, or were you flexible across a week?
That is an excellent question, and thanks for asking it. And it's one that I spent a better part of 2 years trying to figure out. I would say it ended up being around, each year we had around about 80 appointments. Now those ranged from anywhere from 40 minutes to an hour and a half, sometimes 2 hours, based on whatever the family or the patient needed at the time. I tried my best to keep them to a specific day, but at the end of the day, it's based on the patient's and family's needs. So I think what I had to do was be versatile within myself and communicate really well with the specialist nurses and the family. And we kind of co-create and work something out. I know that's not a definitive answer. I really wish I could give you more of a solid one. But I think what I noticed was if I just kept communicating and offering certain times, and if it worked, it worked. If it didn't, well, we would find something else. The only struggle I would say is that once we opened that door and people knew that they had the opportunity for that support, people did take us up on it. And then it continued to grow. So in reality, I tried to keep it to 1 day a week. It did often encroach on the rest of more than a day's time, just because there was so much need.
Thank you.
That's excellent. Any other questions in the room? Yes. No, there's someone coming with a microphone.
Is that working? Excellent. I wondered, I'm interested that you use the word bereavement for the journey of people going through MND. Do you purposely use that rather than anticipatory grief? Do you see there's a specific difference between those two things?
Again, excellent question. It's one that we've been wrestling with for quite a bit over the last couple of years. Often, and I'm not saying it's narrow and limited, but I would hear people use the term anticipatory grief, talking about the emotions they're feeling now because of the often singular event that's coming or events that are coming. And one of the things that was noticing as we were sitting with patients and family, it was often the momentary loss that they have now lost this ability to do this. Mm-hmm. They've lost the ability to play with their grandkids on the floor. They've lost, and the pain that we were seeing or the struggle was often about that, not necessarily about that which was coming. Uh-huh. That was definitely in with the mix, as humans are. We have all those things within us. But it was often the support that was needed for each of those losses. Mm-hmm. So between Ian and I, we started talking about them as continual bereavements. And they have lost this, and they're grieving for that. And now they've lost this, and they're grieving for that. While also keeping in mind that there is that thoughts towards the future that, of course, occurs. And so it's not diminishing anticipatory grief, but it's just saying that it's much broader than that, if that makes sense.
It absolutely does, yes. Thank you. Yeah, thanks.
Thank you. We have an online question.
How did people react or accept your role in terms of that religious spirituality approach? Were they apprehensive?
It's very interesting. Now, in Scotland and in Tayside specific, we have the Scottish approach, which I tried to outline. But even with that approach, it's a term that carries so much weight in history, and that's understandable. And what we noticed initially was how it was presented. The nurses who were quite excited to offer this, but weren't quite sure at the beginning how to do it, and so it was almost apologetic. We have a chaplain, if you might be interested in that type of support. So it's almost apologetically trying to, which I don't know about you guys, that when somebody kind of approaches you that cautiously, it doesn't incite you with confidence to want to take that up. So we just changed the language, which we reversed it without hiding anything. It's like, we have someone on our team, they do patient and family support, they'll do it in your home. And this is who he is. This is what and yes, he is a chaplain, but this is the type of work he does with us. So it was just trying to, again, make that accessible. But every now and then, of course, people would start a conversation with, well, I'm not religious, right? And I was like, absolutely, that's absolutely fine. We're only going to discuss what you'd like to discuss. So I hope that kind of explains some of that.
I think it was a fantastic explanation. I think we have time for one very quick question over here in the corner. Yeah.
Hello, Patrick. My name is Hjördís, and I'm a hospital chaplain in Iceland.
Right.
I'm not sure if you told us already, but I was wondering, do you, in the initial interviews, are they structured like with pre-decided questions?
In the semi-structured interviews that we did at the end to evaluate, is that what you mean?
Yeah.
Yeah. We had 4 questions that we kind of planned, but the people conducting the interviews did so in a way that was, well, they're skilled at what they do. So they would ask the question, but based off the answer, they would allow the patient or family member to elaborate as much as they needed, or if they wanted to include something else. But the initial questions were, can you tell us about the experience of pastoral support you received from the chaplain? And then when the support was offered, was it the right time? Is there another time that would have been more helpful? Would you recommend this type of support? And is there anything else you would like to add that would be helpful for us to know? So you'll see that all the questions are in themselves quite permissive, is, hey, tell us what you think. Mm-hmm. Because that's what we had seen from the previous questions from the prom, is it told us they valued it, but it couldn't tell you why in the way it was done. And so we knew we needed to get into that dialogue, that conversation, and hey, well, what really mattered? What was really important to you? So again, they asked some of the structured questions, but with the ability to elaborate and add in whatever they needed to.
Thank you. Thank you for such a fantastic presentation. Thank you, Patrick, and thank you, Ian.